If we would like to make a claim on the reduces the risk of infections, do we need biomarkers for that? Because it's already stated in the past claim that the ultimate evidence for reducing infections is just to use the symptom diaries and so on and look at the occurrence of infections. So do we need biomarkers for that?
In my view, that depends on the wording of your claim. If you want to claim that our probiotics will reduce the incidence of influenza infection, and you don't need anything else. But if you would like to claim that your product improves your immune system and therefore reduces the risk of infection, then yes, you have to include biomarker.
Yeah. And
so
also,
it depends totally on the wording of the claim.
Yeah, and also I think that it's so that if you want to make a risk reduction claim, you need to have the biomarker where to affect. So what is the biomarker for reducing the risk of infections? And if there isn't any, so we are in a dilemma what to do.
For influenza A and B infections, there it can be done. But in most studies on risk reduction of respiratory tract infections, the pathogens are not identified. So you don't know. It will be rhinoviruses, it will be metapneumovirus, it will be adenovirus, it will be influenza virus, it can be anything. And then it's very difficult, if not impossible, to say, well, what should we then monitor? General immunoglobulin levels, not relevant. Antibody levels, but then you have to know the pathogen. CD8 T cells, as I've shown, may be relevant, but the change that you can expect is only small. So I think there we are still in the open.
You're caught between a rock and a hard place. I think the only real relation you could give is for influenza, and that's very unfortunate, but there is not much more left. And for all other infectious diseases, we do not know the correlates of protection. So there are no reliable biomarkers. You might get away with it, I don't know, but they're just not there.
What about the rhinovirus infection? If we could, that some probiotic reduces rhinovirus infections, then we would make the claim so that reduces the risk of rhinovirus infections, and would we then have a biomarker for that?
But we have not tried submitting. I do studies with challenge studies in the humans with influenza. I don't know of a group who has submitted this to the Medical Ethical Committee for food. If I was a Medical Ethical Committee, I don't know whether I would allow you to challenge a group of student volunteers with either rhinovirus or influenza for a food claim. So that's a big question. We don't yet know whether this... First of all, these experiments are extremely expensive. But second of all, I think in Rotterdam, my Medical Ethical Committee would not approve this. If I would label it as a food, if I would do what some other groups have done, label it as an RX, they might approve it. But.
Then I have another question on the biomarkers. If we can show that the probiotic does something for some biomarker, then okay, if we can say that it increases the level of NK cells or it reduces IL-17 or whatever, if we could have such a claim, what do we then say to the consumer? How interesting is that?
If I would be a consumer, I wouldn't care. I would not be impressed by a claim that my IL-17 production capacity will double or triple, or that my NK cells would increase in activity. Because how should you, as a consumer, interpret those data? I think if you ask a general consumer what your immune system does for you, that you wouldn't get the correct answer. And so how would you know that, what would be the relevant biomarker?
Yeah, I know that, but if we want to, as you said already, there isn't any biomarker for infection, for respiratory tract infection so far. And therefore, if we cannot go to the risk reduction claims on infections, then we would go for affecting the biomarkers. But again, what can we then say to the consumer?
Yeah.
What's the benefit for affecting some biomarker? So what is?
Yeah.
What can we do?
What we need there, that cannot be answered today, but that is a dialogue with regulatory authorities, how to translate those data into a claim that consumers can understand and appreciate. And what is allowed there? Yeah? Be it natural killer cells, antibody levels, cytokine profiles. We need some kind of consensus on how you can translate that. My idea would be that you translate it still something that it improves your immune system to protect against gastrointestinal or respiratory infections. Yeah?
What's also
during the winter or a whole year, or for young children, or maybe for elderly, in those broad categories.
But what's important is that you really look out what wording you use, because you're using exactly the wrong wording. There are biomarkers for infection. That's not the problem. And there are very valid biomarkers for infections, but there are no correlates for protection. So there are no biomarkers that correlate with protection against disease. That's what's not available. There are sufficient biomarkers. Even some of them you could use as primary endpoints. No problem. If you would look at antibodies against rhinovirus, you could say that's a primary endpoint. Does that correlate with protection? No, it doesn't. But it's a perfect valid primary endpoint. So you have to be very precise, because this is where the confusion arises. And people say, oh, I have these primary endpoints and the FDA has accepted them. Yes, but they're not relevant for resistance against disease. And then EFSA will say, well, we only look at the endpoint resistance against disease.
But Eric, isn't it of general public health interest to have these correlates?
Yeah, you know, that's what I said earlier. There's a Nobel Prize to be won there. And that's what I said earlier. There's absolutely, I mean, I have 50 people in viral clinics and 150 people with Osterhaus in the Department of Virology in Rotterdam. We have subsidy up the zoo. I mean, for the coming 4 years, we have over 50 million euro subsidies. If you look at through all these grants we have now from the European Union, from the industry, all of them are about correlates for protection. How can we predict how a rotavirus vaccine will work? How can we predict that for dengue, West Nile, influenza, Ebola? All of them. And all of them come back to that simple point. How can we predict from a cat, a ferret, a chimpanzee, a rhesus monkey model that we have something that will work in the human? That's the essential question. Now, and this is hardcore pharma research. It's not food research. Mm-hmm. So it's much easier, because in pharma you have these very simple questions. In food, you always have these broad questions. Pharma is much simpler than food.